You know that feeling.
Mm-hmm.
That creaky knee when you stand up, maybe.
Yeah.
Or your fingers feeling a bit stiff first thing, and it sticks around.
Yeah.
It's easy to just write it off as, oh, I'm just getting older.
Mm-hmm.
But today, we're really digging into something super common, osteoarthritis, or OA. And it's more than just simple wear and tear.
Exactly. And this is really your focus session on getting a handle on osteoarthritis. Think of it like we're pulling out the absolute must-know stuff from your revision notes.
Right.
Making it stick, but, in audio form. Our mission today is simple. Give you a clear, concise rundown, everything from the basic definition right through to the potential problems.
And we've got it all mapped out.
Yeah.
Specifically what you need to know. We'll cover the definition, what we think causes it, the etiology, then the risk factors,
Yep.
how it actually messes with your joints, the pathophysiology, what else it could be confused with.
Yeah.
It's vital for diagnosis, right?
Absolute critical.
Who gets it, how it typically presents itself, how doctors actually diagnose it, the management options, what to expect long-term, the prognosis, and you have those potential complications too. Basically, you're a fast track to understanding OA.
Let's do it.
So let's dive right in. What exactly is osteoarthritis?
Fundamentally.
Okay, fundamentally, osteoarthritis is a degenerative joint disease. Degenerative is the key word.
Meaning it breaks down over time.
Precisely. It involves a gradual breakdown. Specifically, it's the cartilage, that smooth, cushiony tissue between the bones that starts to wear away. It is the most common type of arthritis. It's progressive, so it tends to develop, sometimes worsen over time.
Okay.
And while technically any joint can be affected, it really prefers the ones that take the most load. Weight-bearing joints?
Like knees and hips.
Exactly. Knees, hips, spine, and also the small joints in the hands are common spots.
And the result of that cartilage wearing down.
Well, the main consequences are pain, stiffness, and a definite drop in how well your joints move. Less mobility. Think of it like the tread on a tire wearing thin. Just doesn't absorb shock the same way. That's a really good analogy. So if the cartilage is wearing down, what actually kicks that process off? What's the cause, the etiology?
That is the big question, isn't it? And the honest answer is we don't have one single definite cause. It seems to be a mix, a complex interplay of different factors. We know genetics can play a part.
So family history matters.
It suggests a predisposition, yeah. Then there's the mechanical stress joints experience over a lifetime. Just daily use adds up.
Right.
And there are probably environmental factors, too, things we're still figuring out. But a huge underlying factor is simply aging.
The inevitable.
Pretty much. Over time, cartilage naturally wears down, and crucially, its ability to repair itself decreases. So usually it's a combination of these things, not just one trigger.
Okay, age is a big one. We've mentioned general wear and tear. What about specific risk factors, things that really up someone's chances of getting OA? What puts extra stress on those joints?
Right, it's a pretty well-defined list. We've said advancing age already. Obesity is another major one.
Because the extra weight.
Exactly. Extra body weight puts a massive mechanical load on knees and hips, speeding up that cartilage breakdown.
Makes sense.
Previous joint injuries are also significant. Things like fractures that involve the joint surface or ligament tears, they can destabilize the joint and increase OA risk down the line.
Right.
Repetitive joint use is another. That could be from certain jobs with repetitive motions or, say, high-impact sports over many years.
Okay.
Family history, like we touched on, points to that genetic link. And interestingly, other medical conditions can tie in too.
Like what?
Things like diabetes, gout, they're associated. Also, pre-existing joint deformities can change the joint mechanics, making OA more likely. Even bone density, having very high or very low density, has been linked.
Interesting.
And finally, there's sex. Women are actually more prone to developing osteoarthritis than men. The reasons aren't perfectly clear, but the link is there.
Wow, that's quite a list. So let's get into the nitty-gritty. What's actually happening inside the joint, the pathophysiology, the mechanics of it at a tissue level?
Okay, so picture that smooth cartilage surface again. In OA, it starts to degrade, to break down.
Right.
And this breakdown process actually releases inflammatory chemicals, which unfortunately cause even more damage within the joint.
A vicious cycle.
Kind of, yeah. As the cartilage gets thinner and wears away, it loses that vital shock-absorbing ability between the bones.
Leading to the symptoms.
Exactly. That reduced cushioning results directly in the pain, the stiffness, the loss of easy movement. Now, the body tries to react.
Oh.
It tries to compensate for the lost cartilage and the instability by forming bony outgrowths around the joint edges. We call these osteophytes.
Bone spurs, right?
Bone spurs, that's the common term, yes. But the problem is, these osteophytes, along with a thickening of the joint capsule, the tissue surrounding the joint, they actually add to the problem. They contribute to more stiffness, more pain, and just general joint dysfunction.
So the body's attempt to fix it actually makes things worse in some ways.
In some ways, yes. It's a cascade. Cartilage damage leads to inflammation and structural changes, which cause the symptoms.
Okay. Now, symptoms like pain and stiffness, they aren't unique to OA, are they? What else could be causing similar problems? What's the differential diagnosis?
That's a super important point. Getting the diagnosis right means ruling out other things. Broadly speaking, you have to consider inflammatory types of arthritis.
Like rheumatoid arthritis.
Exactly. RA is a big one that's autoimmune. Then you've got the crystal arthropathies.
Gout.
Gout, caused by uric acid crystals, and also pseudogout, which involves calcium pyrophosphate crystals. Psoriatic arthritis, which is linked to psoriasis, is another key differential.
Okay. And does it get more specific depending on the joint?
Definitely. If someone comes in with knee pain, for instance, besides OA, you'd think about things like perpatellar bursitis inflammation of the bursa sac in front of the kneecap.
A housemaid's knee?
Sometimes called that, yeah. Also, meniscal tears, very common knee injuries, or cruciate ligament tears, often from sports.
Right.
And crucially, you always have to consider referred pain. Knee pain might actually be coming from a hip problem or even the lower back.
Good point. Okay, what about hip pain then, if it's not hip OA?
For the hip, you'd think about greater trochanteric pain syndrome that causes pain on the outside of the hip. Iliotibial band syndrome, often seen in runners, is another one.
Okay.
A more serious one is osteonecrosis of the hip, where the bone actually dies due to lack of blood supply. And again, referred pain is possible. Hip pain could originate from the knee or the spine.
And our notes mentioned a really long list for any joint pain potentially mimicking OA. What are some highlights there?
Yeah, the list gets broad if the pain isn't clearly localized. You'd consider a fracture near the joint, especially if there's been trauma.
Obvious but important.
Definitely. Beyond the crystal ones we mentioned, you think about infections. Septic arthritis is an emergency. Viral arthritis, reactive arthritis, post-infection.
Okay.
Again, RA and psoriatic arthritis. More serious stuff like malignancy, especially bone metastases, or connective tissue diseases like lupus. Then there are seronegative arthritides like ankylosing spondylitis. And always, always keep referred pain in mind. Plus, some general medical conditions like sarcoidosis or even infective endocarditis can cause joint pain.
That sheer number really underlines why a proper diagnosis is so critical.
Absolutely. You can't just assume it's OA.
So, how common is osteoarthritis? Let's talk epidemiology. Who gets it and how widespread is it?
Oh, it's incredibly common, especially as populations age. In the UK alone, it's estimated something like 8.75 million people seek medical help for it.
It's a huge number.
It really is. And as we've said, the chance of getting it goes up significantly with age, and it's definitely more common in women than men.
Right.
Looking at specific joints, studies show maybe 11% of adults have hip OA visible on X-ray, and for the knee, it's much higher, maybe around 24%.
24%.
Yeah. And while the joint changes might start earlier, people often start feeling the symptoms, the pain and stiffness, in middle age or later. It reflects that cumulative effect of age and other risk factors over time. It's easily one of the most common chronic diseases out there.
Very common,
Yeah.
especially as we age. So if someone is developing OA, what are the classic signs and symptoms? What might they tell their doctor, and what might the doctor find?
The absolute classic symptom is joint pain. Patients usually describe it as a deep ache. Typically, it gets worse with activity, using the joint, and feels better with rest. At least that's how it often starts.
Okay.
Stiffness is another big one, especially noticeable first thing in the morning or after sitting for a while. But, and this is a key point differentiating it from some other types of arthritis,
Yes.
the stiffness in OA usually lasts less than 30 minutes. Sometimes it's barely there at all.
Okay. Good distinction.
They'll likely note a reduced range of motion too, finding it harder to bend or straighten the joint fully. Swelling around the joint is common, and many people report crepitus.
That clicking or grinding sound.
Exactly, that grating, cracking, or popping sound or sensation when they move the joint. As OA gets more advanced, pain might start waking them up at night.
Oof.
Yeah. Location-wise, knee pain is often felt generally around the knee, can be both knees. Hip pain often presents in the groin or the front or side of the thigh. And remember that referral pattern? It can radiate to the knee or even the testicle in men.
Okay, those are the things the patient reports.
Yeah.
What signs might a doctor pick up on during an exam?
Well, the clinician will likely confirm that limited range of movement. They'll find pain when they move the joint, especially pushing it to its limits.
Right.
They might feel swelling, maybe warmth, maybe an effusion, which is fluid buildup, or a thickening of the joint lining, the synovium. There's usually tenderness if they press around the joint, that crepitus we talked about. Often the examiner can actually feel it too. Importantly, you typically don't see systemic signs with OA, no fever, no rash, none of that.
Okay.
As it progresses, you might see visible bony swelling and even deformities because of those osteophytes, the bone spurs.
Ah, like in the hands.
Exactly. In the fingers, those bony bumps are called Heberden's nodes at the joints nearest the fingertips and Bouchard's nodes at the middle joints. You can often see pictures of those.
Right.
The doctor might also find the joint feels a bit unstable and notice some muscle weakness or wasting in the muscles around that joint because it's not being used as much or effectively.
Okay.
We sometimes lump all this together as the osteoarthritis syndrome, joint pain, functional limits, reduced quality of life, all driven by that cartilage loss, bone changes, and low-level inflammation. And remember, it varies a lot person to person, and symptoms can flare up and calm down. Trauma can sometimes trigger it too.
So the diagnosis really hinges on that clinical picture history and exam. What about investigations then? X-rays, blood tests, where do they fit in?
Yeah, the diagnosis is primarily clinical, based on what the patient says and what you find on examination. But imaging, especially X-rays, is really useful
For confirming it.
confirming it, yes, and also getting an idea of how severe it is. There's a great mnemonic for the typical X-ray findings in OA, LISS.
All ISIS.
L is for loss of joint space that shows the cartilage thinning. O is for osteophytes, those bone spurs we keep mentioning. S is for subchondral cysts, little fluid-filled sacs in the bone just under the cartilage. And the final S is for subchondral sclerosis. That's where the bone under the cartilage becomes denser, looks whiter on the X-ray.
Global SS. Loss of joint space, osteophytes, subchondral cysts, subchondral sclerosis. That's really helpful.
It covers the key features you look for. Now, blood tests. They usually aren't helpful for diagnosing OA itself. They're typically normal in OA.
So why do them?
Mainly to rule out other conditions, like rheumatoid arthritis or gout, which do often have specific markers in the blood. So blood tests help exclude the mimics.
Got it. Are there specific guidelines for making that clinical diagnosis without needing an immediate X-ray?
Yes. Nice. The National Institute for Health and Care Excellence in the UK, they have criteria. Basically, if a patient is 5 or older, has activity-related joint pain, and little or no morning stiffness, less than 30 minutes, and there aren't any red flags pointing to something else, you can often make a clinical diagnosis of OA right there without needing imaging straight away. You also want to record their weight and BMI.
That makes sense for streamlining things.
Yeah.
And what about other imaging, like MRI?
MRI isn't routine for OA diagnosis, but it can be useful if you're trying to differentiate from other causes of joint pain, like maybe a meniscal tear or osteonecrosis, which show up better on MRI.
Okay. And joint aspiration, sticking a needle in.
That might be considered if a joint is very swollen. The main reason would be to rule out other causes like infection, septic arthritis, or crystal arthritis, gout, pseudo-gout, by analyzing the fluid, but not routine for typical OA.
Right. Let's shift to management. If someone has OOA, what's the plan? What are the goals?
The main goals are pretty straightforward. Reduce the pain, improve how the joint works function, and generally boost their quality of life.
How do you approach that?
It's usually a multi-pronged attack, combining non-drug strategies, medications, and sometimes, for severe cases, surgery.
Okay, let's break that down. Start with the non-drug stuff. What can people do themselves or with therapists?
These are really the foundation, the core treatments. Absolutely key is weight management if the person is overweight or obese.
Takes the load off.
Massively. Reducing weight significantly cuts down stress on those weight-bearing joints. Exercise is also vital.
What kind of exercise?
The regular, appropriate exercise. It needs to strengthen the muscles around the joint that gives better support and stability. It can also directly improve pain and function. Physical therapy is great here.
How so?
Physios design specific exercise programs, teach you how to move properly, maybe do some hands-on therapy for pain and stiffness. They also advise on pacing activities.
Oh, okay. Anything else non-drug?
Yes, assistive devices can make a big difference. Things like canes, walkers, or even splints and braces to support the joint.
Right.
And just general lifestyle tweaks, avoiding activities that really flare up the pain, learning ways to protect your joints during daily tasks. Education and self-management support are crucial. Heat or cold packs can help too.
So lots you can do without pills.
hmm
But what about medications? What are the options there?
For meds, the first step is often simple pain relief like paracetamol.
Okay.
If that's not enough, non-steroidal anti-inflammatory drugs, NSAIDs, can help with both pain and inflammation.
Like ibuprofen.
Like ibuprofen, naproxen, etc. These come as pills, but also as topical creams or gels.
Applied right on the joint.
Exactly. Which can be good for knees and hands, potentially fewer systemic side effects.
Right.
If pain is more severe or localized in one joint, doctors might consider injecting corticosteroids directly into the joint.
Steroid shots.
Yep. They can give pretty rapid relief, but it's often temporary, maybe lasts a few weeks or months. Hyaluronic acid injections are another option sometimes used, trying to lubricate the joint, but the evidence is a bit mixed on how well they work long term.
Okay.
And then, as we mentioned, if things are really bad, surgery joint replacement is a very effective option.
You mentioned NICE guidelines before. Do they have specific recommendations on how to use these treatments?
They do. NICE really pushes those core treatments first. Support for weight loss and muscle strengthening exercises. Absolutely fundamental.
Right.
For first-line drugs, they recommend paracetamol and topical NSAIDs, especially knee hand. If that doesn't cut it, then consider oral NSAIDs, but often with a PPI, a stomach protector.
Because NSAIDs can irritate the stomach?
Correct. Weaker opioids might be used, but generally only for short-term management of severe pain. Capsaicin cream, made from chili peppers, is an option for hand OA. Intra-articular steroid injections are in the guidelines, too, for flare-ups. They also mention things like supports, braces, Taine-Ness machines, those little electrical nerve stimulators, and shock-absorbing insoles as things to consider.
Okay.
And joint replacement is the final step for people whose quality of life is really hit hard despite trying other things.
What about supplements like glucosamine? Lots of people take those. What do the guidelines say?
Glucosamine and chondroitin. They are components of cartilage. And some people do report feeling better when taking them. But the scientific evidence is really mixed. Some studies show a small benefit, others show none. Because of this inconsistent evidence, NIC, back in their 2008 guideline, specifically recommended against routinely prescribing glucosamine or chondroitin for OA.
So the focus remains on those core treatments: exercise, weight loss, education, AIDS, and then the standard medications.
Pretty much. That's where the strongest evidence lies. Therapeutic exercise, weight management, self-management education, maybe heat-cold therapy, and using AIDS devices appropriately. Then paracetamol topical NSAIDs, then oral NSAID SCOX2 inhibitors, maybe weak opioids short-term if needed, steroid injections for flares.
And when is the right time to think about surgery? When should someone get referred for a joint replacement?
Referral should be on the table when those core treatments just aren't cutting it anymore. When the pain is bad, and it's really limiting what someone can do day to day, impacting their quality of life significantly.
Is it based on X-ray severity?
Not really, no. It's more about the clinical picture, the patient's symptoms, and how much it affects them. You don't need to wait for the X-ray to look terrible. In fact, it's probably better to refer before someone gets into prolonged severe pain and really significant functional decline.
Why is that?
Because that can lead to more muscle weakness, general deconditioning, which can make recovery after surgery harder. You want to operate when the patient can still participate effectively in rehab.
Makes sense. Are there any newer treatments on the horizon, anything cutting edge being researched?
Yeah, research is always ongoing. Our notes mentioned a couple of things being studied. One is magnetic resonance therapy, MRT, using magnetic fields supposedly to stimulate cartilage.
For knee OA.
For knee OA, yes. Another is genicular artery embolization, GAD. That's a minimally invasive procedure blocking tiny blood vessels in the knee, trying to reduce pain signals.
Interesting. But still experimental.
Mostly in research settings, yeah. Not standard care yet, but areas to watch for the future, maybe.
Okay. So looking ahead, what's the long-term picture for someone with OA? What's the prognosis?
It's really variable, depends hugely on how severe it is when diagnosed, which joints are involved, how well someone responds to and sticks with management.
Is there a cure?
No, unfortunately, OA is chronic. There's no cure currently. But, and this is the important bit, it is manageable. With consistent, appropriate management, many people can control their symptoms really well, keep functioning, and lead active lives. Getting diagnosed and starting treatment early generally leads to better outcomes.
Does it vary by joint?
It seems to. Hand OA often has a relatively decent prognosis. Sometimes the finger joint pain can actually settle down over time. Hip OA, though, tends to be a bit tougher. A fair number of people with significant hip OA end up needing a replacement, maybe within 5 years or so if symptoms are bad.
And knees.
Knees are more variable. Symptoms can improve, stay the same for ages, or gradually worsen. It's less predictable than the hip sometimes.
So it's chronic, but being proactive with management is really key. Can you actually prevent OA or at least slow it down?
We can't totally prevent it, especially the age-related component,
Yep.
but you can definitely reduce your risk and potentially slow progression.
How?
Maintaining a healthy weight is probably the single biggest modifiable factor. Lifelong. Regular physical activity, mixing cardio and strength training keeps joints supported and healthy. Trying to avoid significant joint injuries helps, and if you do get injured, proper rehab is crucial.
Okay.
Education is powerful too. Understanding OA helps you manage it. And if you already have OA, sticking to your management plan, weight, exercise, meds when needed, that's the best way to try and slow things down and keep your quality of life up.
We've covered a huge amount. Just finally, what are the potential downsides if OA isn't managed well? Or if it becomes very advanced? What are the complications?
Yeah, there are definite complications if it gets severe or isn't managed. Chronic pain is the big one, obviously.
Affecting sleep, mood?
Absolutely. It can really impact daily function. Over time, you can get joint deformities, which limit mobility even more. That reduced mobility can lead to a loss of independence. Muscle weakness around the joint develops, which makes you less stable, increases fall risk. People often become less physically active overall, which isn't good for general health. There can be side effects from the long-term use of pain medications, too. And coexisting conditions can complicate things. Severe joint damage might necessitate surgery, which itself carries risks.
And the psychological side.
Really important. Persistent pain and disability can definitely lead to psychological effects. Depression, anxiety, a significantly reduced quality of life. It takes a toll.
So it's common, yes, but definitely not trivial. Proactive management seems absolutely vital to try and avoid those complications.
Couldn't agree more.
Okay, let's try and quickly wrap up the key takeaways from this deep dive on osteoarthritis for your revision. It's degenerative, cartilage breaks down.
Right, multifactorial causes, age is big.
Risk factors: age, obesity, injury, genetics. Pathophysiology involves cartilage loss, inflammation, those bone spurs, osteophytes.
And remember, the wide differential diagnosis rule out inflammatory arthritis, gout, etc.
Super common, especially older women. Clinical features: pain, worse with use, brief stiffness, reduced movement, maybe crepitus.
Diagnosis is mainly clinical. X-rays help confirm and show severity using LOS.
Loss of joint space, osteophytes, subchondral cysts, subchondral sclerosis.
Got it. Management core is lifestyle, weight, exercise, then meds, paracetamol, NSAIs, topical oral injections, surgery for severe cases.
Prognosis varies, but management helps. And complications range from chronic pain and lost mobility to psychological impacts.
Exactly. It's chronic, no cure, but definitely manageable to improve quality of life.
Phew. That was a lot, but hopefully really useful.
And maybe a final thought for you to ponder. Given how much mechanical stress influences OA, how could you consciously think about optimizing your own biomechanics, the way you move in daily life and exercise, to potentially support your long-term joint health? Something to consider.
That's a great point. And if you are looking for more resources, particularly for revision on topics like osteoarthritis, definitely check out PassMSRA.com.
And freemus.com too, both excellent resources for medical learning and exam prep.
Absolutely. Well, thanks for joining us for this deep dive into osteoarthritis.